Dr. Bernard, a pediatrician and epidemiologist from Nigeria. He's also the country director for research at the International Foundation Against Infectious Disease in Nigeria, which is a non-governmental research institute in Nigeria, West Africa. And he has over a decade experience working on research in pediatric infectious diseases in Africa. In his current role, he has coordinated the setup and implementation of surveillance programs in different parts of Nigeria and has supported several regional and national disease outbreak activities. We are very honored to have you, Dr. Bernard Ebruke.
Thank you. Thank you, Dr. Dhanya. And good day, everyone. I'll just go right away and share my screen. Right. So good day, everyone. I thank you for this opportunity to present this topic. I'm a pediatrician, so the focus of my talk will be on the peculiarities of Ebola virus disease in children. There might be quite a few overlap with what my colleague, Dr. Ibrahim, has shared concerning the features of Ebola in adults. So I'll try not to repeat some of those features, but I'll try and go over and focus on the peculiarities of the disease presentation in children. So by way of outline, I'm going to speak to I'll give a brief overview, and then I'll speak quickly about the transmission of the disease, particularly as it relates to children. And then I'll speak a bit more on the clinical presentation, laboratory findings, differential diagnosis, and then speak some more on the clinical management, the outcomes, and the fatality. So, so by way of overview, as Dr. Ibrahim has shared extensively, Ebola outbreaks have occurred in different parts of the world, but mostly in Africa. Importantly, they tend to affect mostly adult populations. The outbreaks that were reported in 2013 and 2014 in West Africa, it affected mostly adults. The large outbreak that occurred in West Africa with a spillover into Nigeria, there was significantly lower incidence of the disease in children than in adults. However, children are particularly vulnerable for several reasons. One of those is that the case fatality rate amongst children is particularly high, and this is more so in young children and infants. Also, there are peculiar transmission patterns when it comes to children and the Ebola virus disease. There are also challenges with contact tracing when you have pediatric cases as opposed to adult cases. And then there are also peculiarities around the clinical management in children and the psychological support that is required that might be a bit peculiar to children. Right. So speaking about the transmission, Dr. Ibrahim has already spoken extensively about transmission of the disease. So I'll just focus on a few points here. First of all, it's clear that direct contact with the mucosa or the broken skin with bodily fluids of a case is the common mode of transmission for human to human disease. However, for children in particular, the virus has been detected in samples of saliva, breast milk, and the vaginal secretions, including amniotic fluid. And so that poses an additional or peculiar routes of transmission for young children and neonates. And then particularly the transplacental transvaginal and breastfeeding routes of transmission for neonates are things to pay attention to. Importantly, in many cases, when you have a young child who's affected, it might be difficult to establish the source of transmission in those young children, particularly when the child is not able to speak. He's not yet of the age where he's able to speak. And this is more of a dilemma when there is no clear history of affectation of the parents or other family members. But then we should always keep in mind that children, they interact with other relatives, not just the immediate family, and they also interact with neighbors. So our clinical suspicion should be heightened, and we should consider all these other sources of transmission as well. Speaking about the clinical presentation, as has been mentioned already, the incubation period on average is about 7 to 10 days, with a range of 2 to 21 days. But for infants, that's children less than 1 year old, this could be much shorter compared to the period in older children and adults. Also, it's been reported that younger children, they have shorter average times when we consider the time period from the symptom onset to the period of hospitalization, as well as the time period from the symptom onset to the time of death. Then this illness severity has been shown to correlate very closely with the viral load, such that as the viral load increases, the severity tends to worsen. So looking specifically at the features that children present with, in the early phase, in the first 3 days of the illness, the features are often non-specific, mostly a febrile, non-specific febrile illness. The child might present with fever, chills, poor appetite, and myalgia. But we should remember that fever, though it's common, but it doesn't always occur in all cases, because there have been reports of afebrile cases of Ebola virus disease in children, and so we need to just keep that in mind. In the later phase, a diffuse rash will often develop. The rash is erythematous maculopapular. It often affects the face, the neck, the trunk, and the upper limb. The other symptoms are similar to symptoms that occur in adults: sore throat, conjunctival injection, as has been described already. Respiratory symptoms, abnormal bleeding, multi-organ dysfunction, acute kidney injury, neurologic abnormalities. All of these also occur, as has been described, in adults. A key point here is that children, less likely than adults, they are less likely than adults to report some symptoms, in particular abdominal pain, chest pain, muscle aches, dyspnea, difficulty in swallowing, or hiccups. So again, some peculiarities to be mindful of amongst children. Now I'll go quickly to the laboratory findings. So these include biochemical, hematologic, and serologic changes. Again, quite a good deal of overlap with what has been described in adults already. Hypoglycemia, electrolyte derangements, metabolic acidosis, they are frequently common. Hypoalbuminemia because of the liver affectation, and coagulopathy also happen frequently. Up to 80% of cases, there's been no fever reported. And so leukopenia, thrombocytopenia, usually with counts between 50,000 to 100,000 have been reported. Even though anemia is common, there have also been reports of cases of polycythemia. So I'll speak about some of the peculiar differential diagnoses to be considered when dealing with the disease in children. Of note, because the features are non-specific, it makes the specific clinical diagnosis quite challenging. However, malaria, particularly in malaria endemic regions, is a key and a very common differential diagnosis. Typhoid fever tests openly, and in more stronger presentation of gastrointestinal symptoms and sometimes wing fever. Shigellosis is also a common differential diagnosis in children. Again, a strongly featuring will be a passage of blood-stained stools and diarrhea. And then for meningitis, the neurologic manifestations will be strongly and clearly observable. As has been mentioned previously, other viral hemorrhagic fevers also are key differentials. Now, in terms of the management, clearly supportive care plays a critical role in ensuring that the outcomes are better. Fluid and electrolyte support, use of antipyretics, pain control are key components of supportive care, just as the transfusion of blood products when needed, and in some cases, empiric anti-malaria therapy may be indicated, as well as empiric antibiotic therapy. Now, in terms of specific care, there's no established or widely used specific therapies. However, and this applies not to the Bundibugyo virus disease, is more to the Ebola virus disease caused by the other variants. There has been shown that monoclonal antibody-based therapies have been shown to be effective virus disease. In terms of vaccines, there are two vaccine regimens that have been shown to provide protection against the Zaire variant of the Ebola virus, and that's the Merck vaccine, the Merck Zebov regimen, as well as the Janssen vaccine regimen. So I'll close in a few minutes. I'll speak now on the clinical outcomes. For the cases that are non-fatal in children, typically you will expect to see improvements in about 1 to 2 weeks after the onset of symptoms. However, fatality amongst children is quite high, in the range of 70% and above amongst affected cases. And so Ebola disease that has been confirmed in pregnancy has been reported to be associated with fetal loss up to 70% in some series, and neonatal death as much as 90%. The high fatality has also been reported in infants and young children. Higher and is observed in older children, and where fatality is in the rate of 50%. As mentioned earlier, fatality risk increases with increasing viral load. So I'll stop here. I've just covered just some key points that are peculiar to the Ebola virus disease in children. And then I'll stop here. Happy to take questions. Thank you.